Welcome to the Neuromodulation Podcast, presented to you by the International Neuromodulation Society. Dive into the forefront of today's emerging neuromodulation techniques, insights, and ethical and clinical applications. Subscribe now to join the multidisciplinary collaboration of medical care providers, scientists, and engineers who are part of the global conversation that's shaping the future of healthcare.
Hello everyone and welcome to the INS podcast. It is not only my pleasure today, but my honour to have the topic of placebo effect in neuromodulation. And my esteemed guest is my good close friend, Professor Robert Levy of Florida, United States, editor of our journal. Robert, welcome.
Thank you so much.
So the placebo effect it's well known, it's well documented and well researched, but typically, we're used to it in the pharmaceutical world in terms of how we look at it in terms of a clinical trial, but we're kind of less experienced with it in the neuromodulation world, in the medical device world. Does it have an effect in the neuromodulation world? What does it look like?
It would seem as if we are just discovering the placebo effect in neuromodulation. But in fact, while spinal cord stimulation has been in clinical practice since the early 1970s, it has been almost that long that people have been evaluating and concerned about the placebo effect in neuromodulation. So some of the first papers occurred in 1980 or 1981, asking whether spinal cord stimulation or deep brain stimulation for chronic pain were in fact subject to placebo effects. In fact, as you would expect when treating a partially subjective disorder such as chronic pain, which is multifactorial, and the definition of pain involves not only nociception, the feeling of pain, but the interpretation and emotional impact of the pain on the person. So it would seem that it was possible, if not likely, that there is a placebo effect in spinal cord stimulation or pain therapy in general. And the fact of the matter is that there are many papers that have written over the last 40 years identifying and documenting some placebo effect of spinal cord stimulation. It's very interesting that there are few, if any, studies that have a placebo arm looking at spinal cord stimulation, for example. Only one that I know of that is a reflection of people in the field concerned, in fact, that they might detect a placebo effect that would somehow negate the acceptance of the therapy. And as I'll talk about a little later, that's not necessarily bad. That is, if you have both a measurable physiologic effect and a placebo effect, then perhaps you can amplify the placebo effect and use it to better benefit patients. But let me say this one thing. It's really not accurate to talk about placebo and physiologic effect because the placebo effect is, in fact, a physiologic effect.
So the circuitry is actually the same?
It's actually different, but the circuitry exists. So functional MRI studies and electrical stimulation studies have shown that there are two parts of the placebo response. There's the expectation phase and then the activation or experiential phase. And while they involve several common features, they also have several unique areas that are involved. And if you look at the pain circuitry, and if you look at the placebo circuitry, while there's certainly some overlap, they are quite different. And both are activated, for example, in patients who are treated with spinal cord stimulation.
So, I mean, that's absolutely fascinating. And when I talk to clinicians in the field, it's almost as if they don't want to admit the existence of this. They will say to me, oh, it's impossible. It can last 2 weeks. That's why we do a trial. It couldn't last 3 months. It couldn't last 6 months. But what is not only your experience, but what does the evidence say about the durability of this?
It's really remarkable because as I was trained, the physiologic effect, that is the measurable effect of the placebo, was something that waned within 30 days, 3 months, whatever length they put on it, which was largely purely conjecture. But the fact of the matter is that the placebo effect can persist for quite a long time. And again, if you use methods that amplify the placebo effect, you may not only get a better initial response, but a better ongoing response to therapy.
Now that is a very interesting concept.
Yeah, and it's important for us to differentiate whether we're talking about research or clinical practice. As a primary researcher, to me, the placebo effect is horrible. It's a bad thing because it makes it harder for me to determine the true biological effect versus the physiologic placebo effect. And separating the two is actually quite important in research terms. So there's no question but that in research, particularly in neuromodulation research, where you don't necessarily have purely objective outcomes, that you are able to differentiate and minimize the placebo effect. On the other hand, in clinical practice, if you can amplify effect and make a patient feel better, who cares? And so that's really where my thinking has changed dramatically over the course of the past 20 years, in that regardless in my clinical practice, if I can amplify the effect, I should.
So it would be anathema to us all to be delivering something that was in fact indistinguishable from placebo. But having established efficacy above and beyond placebo, it is in the patient's interest if we can optimize their outcome and harness the placebo response. That's essentially what you're saying.
Absolutely. And surprisingly, not surprisingly, when we look at something like deep brain stimulation for pain control, we see the very same kind of placebo effect. And when we do functional MRI and EEG studies, we see activation of both. The expectation...
Surely not for tremor. Even for tremor...
We'll get there. And surely not is what you would expect, but radically wrong. But before we get to that, deep brain stimulation for chronic pain, you would expect probably has a similar placebo profile as spinal cord stimulation, and yes, in fact, it does. But what really turned the field on its head was the identification that a pure physiologic effect, such as what we use in deep brain stimulation for movement disorders, we have always thought you stimulate the circuitry within the basal ganglia, you block a pattern of abnormal activity, and as a result, your tremor or your on or off phases or your imbalanced gait, all of those things then get better. And that's a beautiful model. In fact, it's the model that we relied on to sell deep brain stimulation for movement disorders for decades. The fact is, however, that the overall effectiveness of DBS for treating Parkinson's or Parkinson's features is about 90%, somewhere between 80 and 90%. And careful studies that have been done have shown that fully 39%, let's say 40% for comfort, 40% of the effect on gait instability, tremor, all of the things that we identify as the physiologic features of Parkinson's disease, about half of them are due to a placebo effect. And primarily it has to do with patients' expectation of benefit. So if they expect benefit, if they think that the device is going to work with them, if their physicians are supportive in a significant way, those patients do almost twice as well as the patients who get the very same therapy but aren't primed or don't believe that the therapy will help them.
So that might be one of the few times where skepticism doesn't work in your favor.
In fact, yes. For decades in my practice, as I would approach potential patients and patients who actually followed through with procedures, I would tell them, I'm not sure this is going to help you. That's why we do a trial. That's why we test in advance. And this kind of limited expectation that I purposely sent to patients in order to manage their expectations so that if they didn't get benefit, they wouldn't be as upset or as angry. Now, it's strongly suggested that what that means is that I have been inhibiting the effectiveness of my treatment. And so one thing that has changed since I became involved in evaluating the neuromodulation placebo effect is that in all of my research studies, I'm very careful to give the appropriate discussion about risks, benefits, alternatives, very realistic presentation of what I think the potential outcomes of the study may or may not be, which significantly limits the placebo effect. But in my clinical practice, I tell patients that I have great expectations that this will help them, that there is an 80 to 90% chance that they will get strong benefit from this treatment. And it's not misleading patients. I mean, that's very factual, but it also allows me to attempt to improve their expectations and thus increase the effectiveness of the procedure and minimize their chances of losing a placebo effect that might be additive to the physiologic effect, and ultimately they can get a better result from the treatment.
Does that at times possibly bring a dynamic tension between patient-informed consent and optimizing patient outcome?
That's why I made the point that we are factual and yet encouraging. That is, now in the real world population of patients who are receiving deep brain stimulation, where they're not in a study that is looking at the placebo effect, 80 to 90% of patients do get good effect. And so to tell a patient that in a clinical setting is not only accurate, but it's also encouraging. It also helps to support their expectation, and we know that expectation, a positive expectation, triggers those mechanisms of brain activation that underlie both the expectation and the execution phase of placebo effect.
So in terms of sort of more nuts and bolts things, do we have any knowledge of things that can increase the placebo effect, decrease the placebo effect? That is, the degree of invasiveness, does that have an effect? The amount of clinic time they have, the interaction with a rep or the physician. Are there factors that are known that can make it go up or make it go down?
There's always been concern about that. And thankfully, the most recent recommendations in terms of neuromodulation research involve building a system where you have very strong control of biases and very strong control of patients having expectations based upon the interaction with the caregiver. So in a research setting, we have bias analysis, we have a way of looking at how patients believe or don't believe, what they expect to get from the procedure as told to them by their caregivers. And so that is a very effective way of minimizing those effects. In clinical practice, no one has really looked at it before. And certainly in my clinical practice up until 5-10 years ago, I worked hard to eliminate that potential placebo effect. And in eliminating that potential placebo effect, I have, as I said, potentially decreased the effectiveness. But no one has really systematically looked at a clinical practice that's not part of a clinical study to compare how the interaction with the physician or the other healthcare providers and the patient predicts success. We do suspect, for example, in spinal cord stimulation for pain, there have been studies where even though they were randomized controlled trials, different groups of patients had their caregivers spend different amounts of time with them, different amounts of time programming their device, got cued messages about the effectiveness of the device, like, we really think that this new technology is going to help you, while the other group got, you're getting the old-fashioned device. And those kind of things are clearly effective in increasing or decreasing the effect, and in many respects invalidating the results of the study. So nowadays, in designing these studies, we work very hard to have the treaters blinded, to have the patients blinded, to have the programmers be the only people who know whether they're getting group A or group B, and the programmers are given a script to be able to tell patients the same thing, to spend the same amount of time with patients, and the only difference being at the end of programming, one device goes on, the other device goes off. And doing that, we are able to control the potential bias that also is what triggers the expectation, which is what triggers the placebo effect. So in clinical studies, people have done tremendously in the last 10 years to refine both eliminating the placebo effect by study design, scripting, timing, blinding on both sides. But in clinical practice, we are in a little bit of an unknown.
So perhaps that might mean that historically, some of the variation in results from Centre A, Centre B, Centre C, there was always Centre F that somehow never got good results, could well have come from, one individual was phlegmatic in their approach to the patients, another was charismatic, and that could have included the variability.
I think that we need to look with a newer perspective on those kind of questions. In the past, we either said Dr. A is a great selector of patients who are appropriate for the procedure, or Dr. B can't select patients, or Surgeon A has very poor skills, and Surgeon B is an artist, and it always works for them. But we've never really examined the interaction between the patient and the surgeon or the caregiver to see just how much of differences across centers may be related to the induction of or the inhibition of the placebo effect. And remember, on the other side of placebo is nocebo. There are manipulations that have the due opposite effect of inducing a placebo effect, but biasing patients' expectations and ultimately inducing a higher risk of failure of the procedure.
So if a patient received a certain expectation based on real-world evidence that had historically been able to be achieved, they were then exposed to social media messaging of a negative manner that was not supported by any real-world evidence, that could have a nocebo effect on their outcome.
I absolutely think that's part of what we're dealing with, for example, in the current use of spinal cord stimulation for chronic pain. Most people, when they go to the internet for information, have no idea how to discriminate good information from bad information. And there are many people who are perfectly comfortable putting misinformation and personally biased information on the internet without any qualification. And we're the ones, and the patients are the ones who suffer. And the reason that they suffer is that patients may, for example, say, I'm not even going to consider the procedure. Or if they do go ahead with the procedure, they're so negatively biased that the nocebo effect kicks in, and the circuitry that we see on functional MRI of nocebo is actually slightly different than that for placebo. So there's activation of overlapping but different systems. And the nocebo effect can be working against the clinician and the patient. So the patient's chances of success are lower, and the physician may become disenchanted, not with the patient, but the procedure. If people get filled up with bad information, and a lot of their patients are biased by bad information on the internet, his results may drop. And I think it's important for us to be aware of the impact of these biases to try to counter them. And that's, for example, why I've been a strong advocate of education, not just of implanters and doctors, but of the general public by the International Neuromodulation Society. And I think the more we can put unbiased, factually based information into the hands of potential patients, we not only inform them, but we in fact may provide enough input that is facing against a potential nocebo effect with a placebo effect that may even things out.
Now, when I've talked to patients about placebo at times, occasionally I've had a negative response from them. They've felt that I'm saying that they're stupid, that they're gullible, that they're easily led, and they've been insulted by my raising the mere existence of placebo. Or they felt that I am saying it's all in their head and they can't distinguish things. So sometimes maybe the language I've used hasn't been right to communicate with them. How do we have that communication, language-wise, with the patient?
It's all education. And I will sit down with patients who raise those issues and tell them just what I've told you. Most patients, while they may not be doctors or university graduates, can understand what we're talking about now very clearly as it applies to their healthcare. And if they understand that this is a real response, that you can do a brain scan and show where that response is and how it occurs, it's just part of the effect of the therapy. I would be very surprised to hear someone say that they felt that we were judging them or unfairly skewing the therapy. And frankly, I have this discussion not infrequently, mostly in my DBS patients, but occasionally with my spinal cord stimulation patients as well. In the spinal cord stimulation, because it's so clearly open to bias, it's so clearly open to placebo effect, because our understanding of pain is so nebulous and unfocused, I just go ahead and use the placebo effect unless I'm running a study. And in a study, I've designed that study aggressively to eliminate the placebo effect. But it's very different. Clinical practice versus research practice, and what we're trying to do, what we're trying to accomplish, what our goals are. And I would posit that the goals of research are highly different than our goals of clinical therapy.
Yeah. You've thought long and deep on this subject. What do you feel as a field we can learn from the experience and your review of these things?
I'm glad to say that I'm leaning on the shoulders of the giants who have come before me. There's been a lot of thinking in this area, and the problem is that thinking is reflected in some cases, 40-year-old journal articles, which no trainee, no resident, no fellow, and in fact, no clinical practitioner that I know is even aware of. And that's one of the reasons that I've been giving talks like this at national and international meetings, and why we're doing this podcast. We need to educate ourselves and then use that education to inform our patients and our referring doctors about the placebo effect, the differences between clinical research and clinical practice, and how we can actually amplify and maintain the placebo effect by having people work on their expectations. Another thing that I've done is that while all of my patients see a clinical psychologist for screening before their procedures, whether it's spinal cord stimulation for pain or deep brain stimulation for tremor, while they all see a psychologist, I also have the psychologist, if they're able to, work with them in 2 or 3 visits to help them understand and help them overcome their biases or be aware of their biases so they're more open to having a higher expectation and having a better effect. Yeah. And he's open with that. In other words, it's not subterfuge. It's people who have a greater expectation of doing well, do better, and let's work on what your expectations are and your thinking is. And so they're full partners in this educational exchange.
And that's something that the patients have taken on board and been quite comfortable with.
I believe so. Yeah. They haven't complained to me.
What does the future hold? Where's the next steps in research on placebo itself?
We really need to understand, first of all, which procedures and which diseases have different profiles. And while I can say definitively that deep brain stimulation for pain, spinal cord stimulation for pain, deep brain stimulation for movement disorders, I can say definitively that there is a significant part of their effect that is related to placebo as opposed to physiology. But I don't really know just how much it is for one therapy or another, or for one disorder or another. So we need more sensitive and more focused studies that allow us to give better information. And we also need studies that compare what I used to do to what I do now across the medical community, and see whether or not having a patient see a psychologist, working on their biases and expectations, whether the way I approach it, whether that does result in a randomized, controlled, properly designed study. Do patients actually do better? And if they do, then this has to be part of every surgeon's or implanter's education and clinical practice.
That will be a sea change.
Indeed.
I think the future is very interesting. Robert, this has been a most wonderful and deep dive into the subject. Thank you so much for today.
Oh, it's my pleasure. Thank you, Mark.